Ella está apenas llegando a 400 papers indexados. Es profesora de la Universidad de Duke. Ha sido entrenada en Johns Hopkins en varias etapas de su vida. Está dedicada al tema que nos va a tocar y estamos todos muy expectantes de la labor que va a hacer y admirándole su gran carrera como hepatóloga dedicada a fatty liver y a NASH. Doctora, bienvenida a México.
Thank you. Thank you very much for your kind introduction and for letting me speak to you again on a Saturday morning. Thank you for coming. What I'd like to do today is talk about what we have learned from the studies that we have been doing about treatment of fatty liver disease. As we said yesterday, non-alcoholic fatty liver disease is the liver disease that is associated with obesity and the metabolic syndrome. Because obesity and the metabolic syndrome are very common, non-alcoholic fatty liver disease is very common. At least 25% of American adults have some form of fatty liver disease, and we estimate that about a quarter of these, or about 5 to 10% of our population, have the more serious form of fatty liver disease called NASH, or non-alcoholic steatohepatitis. It's important to distinguish people with and without NASH, and that's because having NASH conveys a much more ominous outcome for patients. People who simply have fatty liver seldom progress to cirrhosis or hepatocellular carcinoma, but some of them do progress to NASH. The people who develop NASH have a much higher risk of developing cirrhosis or liver cancer. However, it's not inevitable. Many patients with NASH can have stable disease for decades, and some can even improve. And so we need to try to understand better which patients with fatty liver disease are most destined to have the worst outcomes so that we can better understand how to manage these patients. But we know that this is a serious issue. It's already prevalent. Some of the people that have NASH are going on to develop cirrhosis. NAFLD-related cirrhosis is becoming the most common indication for liver transplantation in the United States. And the incidence of NAFLD, NASH, and NASH-related cirrhosis are rising because of the epidemic of childhood obesity. So I think that information tells us that we need to do something. We should probably be treating patients with fatty liver disease, but now we have to ask, who should we treat, and what are we trying to get rid of? Is it the fat? Is it the inflammation? Is it the cell death? Or is it the scar? Well, for those of you who picked fat, and you just want to treat people who simply have steatosis, you'll probably be successful, because fat is notoriously transient and it's very easy to reverse. You could argue that this is a worthwhile goal because fat is not totally innocuous. We know that liver fat increases the risk for cardiovascular disease and many types of cancer. On the other hand, many people have fatty liver, and most of them never die of liver disease. This is a disease that has a very indolent course. And so if you selected treating simple steatosis, your therapy would need to be very safe. If you think we should treat NASH, this is a reasonable idea because we know that NASH increases the risk for outcomes that cause liver-specific morbidity and mortality, like cirrhosis and cancer. But as we said earlier, not everyone with NASH develops cirrhosis and cancer, and some people may even get better. So if you pick NASH, again, you have to have a safe treatment, And it would have to be effective. It would have to get rid of the features that actually end up leading to cirrhosis and cancer, and that is the liver cell injury and the inflammatory response. Now, if you pick fibrosis, you're on pretty safe ground because there's no question that fibrosis is a biomarker for eventual bad outcomes of all kinds of liver disease. On the other hand, fibrosis can regress, and there may be a window of opportunity. Some people have argued if you let the scarring get too bad, it might not be reversible. So if you picked fibrosis, your drug would need to be effective at reversing the existing scar and ideally remove stimulus for new scarring, and it would have to be safe for people who have severely damaged and presumably fragile livers. So, who should we treat? Why should we treat? And what should we treat with? Well, when I'm faced with questions like that, I think I should work on something that I know will matter. And here I've pulled out key information from Paul Angulo's last paper. And I think this paper will end up being a landmark paper for the fatty liver field. Because what Paul discovered was that liver fibrosis is the only independent predictor of liver-specific mortality, liver-specific morbidity, and all-cause mortality in patients with NAFLD. This was actually quite surprising to everybody working in the NAFLD field because they thought it would be related to BMI or to insulin resistance or to type 2 diabetes or to the components of the NAFLD activity score, but it wasn't. The only thing that matters is whether or not you develop fibrosis. So we need to understand who gets fibrosis and why. Well, remember we said that there are two kinds of fatty liver disease, the type that just gives you fat in the liver and the type that's associated with liver cell death. And it's the type that's associated with liver cell death that has the chance of progressing to cirrhosis or liver cancer. So why is liver cell death so important? Well, this gets back a little bit to what we talked about yesterday. When cells die, they release signals that inform the rest of the tissue and the body that those cells need to be replaced, and that initiates various regenerative or wound healing responses so that the tissue can be repaired. For a number of years, my group has been studying this model, and I think Paul Angulo's paper would suggest that this is probably a pretty valid idea. Let me walk you through it. So people start with healthy livers. They get exposed to things that make them have fatty liver. Most of them can tolerate those stresses, and they never get NASH. And in fact, if you remove the stimulus for the fat formation, they can actually go back and have a healthy liver. A subset of people with fatty liver can't tolerate that stress so well. They go on and get NASH, but even then, they're pretty well compensated, and they can sometimes get back to just having a fatty liver and maybe even get back to normal. But there's a subset of people who have NASH that have defective repair, and they are unable to recover from the liver damage that is occurring in NASH. And so instead of having an effective wound healing response and replacing the cells that die with other liver cells, they replace the cells that die with fibrosis or scar, or they have a malignancy develop. And so you could argue that the people who have cirrhosis and liver cancer in NASH are the subgroup of NASH people who have defective repair. So what we've said so far is that the outcomes of NAFLD are heterogeneous. A benign liver prognosis despite prolonged exposure to risk factors like obesity and insulin resistance is actually the norm. High liver-specific morbidity and mortality do occur in the subpopulation that develops progressive liver damage, i.e. when functional liver tissue is replaced by scar. Progressive scarring results when injury overwhelms repair, and this could happen either because there's chronic severe injury that would overwhelm even a normal repair response, or that repair is defective and can't keep pace with even mild chronic injury. And that's why Paul found that it's not really whether or not you have injury that matters, it's whether or not you can repair the injury that you have. If you have only mild injury but you can't repair, you will end up with cirrhosis and do poorly. And if you have severe injury, even if you are a great repairer, you may end up with fibrosis, cirrhosis, and do poorly. So treatment is guided for us doctors by an accurate assessment of the risk for scarring. So, and when we see patients with NAFLD, we should now realize that it's not so important to know how much fat they have. It's not really even so much important to know how much inflammation or fibrosis. But what we really have to know is how much they're scarring. We'll get a handle on that by knowing how much injury they have, because the more injury they have, the more likely they are to scar. But ultimately, we have to stage fibrosis. So how do I do this in my clinical practice? Well, fatty liver is very, very common. We can't be doing invasive testing on everybody with fatty liver. So I try to pick people who are at high risk for having fibrosis. Old studies had shown us that if you're over the age of 45 or 50 and obese or type 2 diabetic, you have a high risk of liver fibrosis. If you have a family history of cirrhosis, liver cancer, or type 2 diabetes, you're at high risk for fibrosis. And if you have evidence of end organ damage in other tissues like portal hypertension, polycystic ovary syndrome, or hypothalamic pituitary tumors, those populations are very enriched with people who are likely to have fibrosis. So then, once I've identified a group that I think is at high risk for fibrosis, I do further testing, obviously physical examination, blood test. Now we have more sophisticated imaging, including FibroScan. Some people may justify biopsy, and of course we're still looking for biomarkers. At the end of the day, though, I end up coming with some sort of an estimate of how much fibrosis is present. In my practice, if a patient simply has NASH and very little fibrosis, I generally follow them relatively conservatively, although I do worry that they may be at risk for developing fibrosis at a later date. If my evaluation has already identified fibrosis, F2 or F3, 4, I think it's appropriate to intervene. So now, having figured out who we should treat and why we should treat, what do we treat them with? Well, let's review quickly the clinical trial information, but before doing that, I want to remind you that most of the therapies have been tested in people with low risk for progressive fibrosis. And they studied improvement of fat as a measure of treatment success. Even the studies that evaluated more rigorous endpoints only had a few responders, and those responders have really not been followed long enough for us to assess the impact on fibrosis progression or on fibrosis-dependent clinical outcomes. So what's worked? Lifestyle works. And I don't know how many of you have had the chance to read the August issue of Gastroenterology, but there is a very nice clinical trial in there evaluating how much weight you have to lose to get rid of NASH. Sadly, in women, it's about 7 to 10% of excess body mass. In men, it's about 5%. But diet and exercise do work, and the latest studies confirm that. Vitamin E decreased the NAS score in non-cirrhotic, non-diabetic patients with NASH. It had no impact on fibrosis, but one could argue that the study was not designed to look at fibrosis because most of the population did not have fibrosis. and it does increase the risk for prostate cancer. Insulin sensitizers have been studied, pioglitazone, rosiglitazone. Like vitamin E, they tend to improve NASH, but the pioglitazone study improved NASH even though not all the patients had improved insulin resistance, and they did get more weight gain. So I think practitioners probably are not going to use pioglitazone or rosiglitazone as first-line therapies for NASH. We talked a little bit about metformin yesterday, and remember, it was not effective, at least in children. Obeticholic acid is the new kid on the block. It improves NASH and fibrosis in both diabetic and non-diabetic patients, including subjects with advanced fibrosis. The downside was that it exacerbated dyslipidemia and insulin resistance, so FDA approval is still pending. Well, there is light on the horizon. As you may be aware, industry is all over this field now, and they are developing anti-fibrotic agents. The current agents target matrix remodeling. But as this work is going on, driver pathways for fibrosis are being identified. I know that you are aware that in cancer there was a big initiative to find driver pathways that cause cancer. These are conserved pathways that become deregulated in many tumors. The same idea is now going forward in the fibrosis field, and driver pathways, i.e. pathways that become abnormal in all kinds of tissue fibrosis, are being identified. Recent breakthroughs in preclinical models focus on blaming the myofibroblasts for fibrosis progression, and we now know that these myofibroblasts come from tissue-resident pericytes in the liver. They're called stellate cells. This is important because these pericytes don't just give you fibroblasts, they are actually stem cells, and therefore may be reprogrammable to enhance repair. So the bottom line is effective treatments for NAFLD and NASH are already available. However, their impact on fibrosis and fibrosis-dependent clinical outcomes are still uncertain for most of them, but anti-fibrotic approaches are actually in clinical trial right now, and more anti-fibrotic agents are being developed. In the last part of the talk, I thought I'd focus on something that I suspect most of you would love to see happen. That is a therapy that's based on manipulation of the microbiome. I think people are now beginning to call this the gut-liver-brain axis. It controls energy balance, and we said energy balance is deregulated in the metabolic syndrome, and you get tissue damage. One of the kinds of tissue damage you get is NAFLD. This gut-liver-brain axis is regulated by inter-organ dialogue involving hormones, adipocytokines, bile acids, and metabolites. And these various words are formed not just by us and our tissues, but by them, the microbiome. And so the question is, can we change the conversation with any of our treatments, and would that help the metabolic syndrome or help NAFLD? Actually, there's been a fair amount of data about bariatric surgery and its efficacy on many of the outcomes of the metabolic syndrome, including obesity and diabetes. And again, in the August issue of Gastroenterology, there's a very nice paper demonstrating the efficacy of bariatric surgery in causing reversal of NASH, but the authors still hedge a little bit about its efficacy on fibrosis. So I think more work needs to be done in that regard. But what we're really looking at is, could we do something to manipulate the microbiome? And is there any justification for that? Certainly, we now know that interactions between host and the microbiome govern health. And we talked yesterday about the fact that the microbiome is altered by obesity, and that the microbiome can transfer obesity. But what I'm going to share with you in the last few minutes is the evidence in animal models saying that the microbiome can transfer every single stage of NAFLD. It can transfer steatosis, it can transfer NASH, it can transfer fibrosis, and it can transfer cancer. So in this study, the authors took mice, they put them on a high-fat diet, and some of the mice got NAFL and some didn't. They called the mice that got NAFL responders, and the mice that didn't get NAFL non-responders. They took the fecal microbiome from the responders, and they gave it to germ-free mice, put them on a high-fat diet, and those animals were more likely to have NAFL than the germ-free mice that got the fecal microbiome from the animals that were NAFL resistant. So in other words, the susceptibility to developing fatty liver is dependent upon the microbiome. In this study, the authors looked at, can the microbiome convey susceptibility to NASH? So on the right side of this slide, if you take mice and you put them on a special diet, they will develop NASH. Remember we talked about those inflammasome deficient mice yesterday? Well, if you put them on the same diet, they actually get worse NASH. And that's because they get a dysbiosis, an alteration in their gut microbiome that increases the exposure of the liver to toll-like receptor agonists. They then went on to show that this susceptibility that is conveyed by knocking down the inflammasomes is the microbiome. So if you look on the left side, if you take the NLRP6 and NLRP3 knockout mice that have the defective inflammasomes and are more susceptible to NASH, and you co-house them with wild-type mice, the wild-type mice now become more susceptible to NASH, even though they have a normal genome. So that means that something about the wild-type mice, they caught NASH, if you will, from their cage mates. So it was transferable, which suggests it's an infectious agent. If it's an infectious agent and we give the inflammasome-deficient mice antibiotics and repeat the experiment, then the wild-type mice should no longer catch NASH because the inflammasome-deficient mice don't have an altered microbiome, and that's what happened. So this proves that the microbiome in the gut can transfer NASH. One of the final studies looked at the effect of the microbiome on fibrosis. If you look on the right side, if you take normal mice and you give them a bile duct ligation, they get liver fibrosis. If you take mice and you put them on a high-fat diet and you do a bile duct ligation, they get worse liver fibrosis. Again, the high-fat diet causes the microbiome to change. So if you take the microbiome from the bile duct ligated mice that are susceptible to fibrosis and you give it to regular mice, they're more susceptible to liver fibrosis after a bile duct ligation. So the microflora are transferring susceptibility to fat, they're transferring susceptibility to NASH, they're transferring susceptibility to fibrosis, and these studies show that they transfer susceptibility to cancer. So if you take wild-type mice on the extreme left and you feed them a high-fat diet, you heard maybe from the Barrett's esophagus talk about the bile acid deoxycholic acid. These mice make more deoxycholic acid and they get more liver cancer. If you give those mice an antibiotic, they make less deoxycholic acid and they get less liver cancer. If you take the animals that you just protected from liver cancer with the antibiotic and you give back the deoxycholic acid, they get liver cancer. So the idea here is that the high-fat diet, which induces obesity, alters the microbiome. The microbiome makes toxic bile acids like deoxycholic acid, and those toxic bile acids can cause cancer. So what all of that shows is that at least in rodent models of fatty liver disease, the microbiome changes, increase the intestinal permeability, and or enhance the production of certain secondary bile acids that promote susceptibility to NASH, scarring, and liver cancer. But much more research is necessary to determine if the same is true in people. So now, even though there's tremendous enthusiasm to do fecal transplantation and to give antibiotics to prevent NASH, we might be causing more problems than we help. We still need much more information. So treating people with antibiotics just to get rid of NASH or doing fecal transplantation is premature. So the take-home message is NAFLD is a common, heterogeneous. About 10 to 15% of patients will go on to develop life-threatening liver outcomes such as cirrhosis and liver cancer. The severity of liver fibrosis is the only independent predictor of bad liver outcomes in NAFLD, and only age and severity of NASH predict fibrosis risk. So as doctors, we should focus on diagnostic efforts that will be identifying patients at risk for fibrosis and detecting and staging fibrosis to determine prognosis and let that guide our treatment. Antifibrotic efficacies of currently available treatments are not well established, but new antifibrotic approaches are coming. The microbiome might be a new diagnostic or therapeutic target for us because, at least in animals, it conveys susceptibility to NASH, liver fibrosis, and liver cancer, but more research is necessary to determine if the same is true in humans, and if so, how we could engineer a more benevolent microenvironment. Thank you.
Que nos acompañen en la mesa para la discusión.